Then we can go on to our next presentation. Philip Szavay is from Luzern in Switzerland nowadays. Our history goes back a long time, Philip, and I'm very interested to hear about your experience in the thoracoscopic surgery for TEF and EA.
Well, thanks, David. It's a pleasure to be here and to participate in this very fruitful masterclass of both the Society, ESPES, and IPEG. And it's true what you said, that the history is dating back a long time ago when I was doing my first cases in thoracoscopic TEF repairs, and I didn't even know really how to put a trocar in, and I called you just upon going to the OR, and you helped me out on the telephone. Well, history of minimal invasive surgery, and especially of TEF repair, is somehow linked to German history. At November 9, 1989, when the Berlin Wall came down, there was a meeting in Berlin about laser medicine and also a little bit about minimal invasive surgery, and there was the first report on laparoscopic appendectomy in a child. Exactly 10 years later, on the occasion of another meeting, Tom Loeb and Steve Rottenberg carried out the first thoracoscopic repair of a true esophageal atresia, again in Berlin. That was the surgical first, and since then the publications dealing with minimal invasive surgery for TEF and esophageal atresia, just the titles give us an impression of where we're going to be right now, from the surgical first about the way to go, then lessons learned and current controversies, evolution of technique, update, simulation, and then still and even long gap atresias being approached thoracoscopically. It has been a true evolution of technique in terms of introducing thoracoscopy to TEF and esophageal atresia repair, and just the illustration show us the difference from an open thoracotomy where the view and the side was not even that quite nice as being illustrated in the drawings on the left side. And there was sometimes a little small hole where you could barely watch what the surgeon was doing. And except for the surgeon who was performing it, there was nothing much to see for any other people joining the operation. And then with the minimal invasive techniques, a visualization and brilliant high definition pictures is now possible, so everybody can watch what we're doing right now. There is evidence for minimal invasive surgery for TEF and EA. This recent published systematic review and meta-analysis dealing with 8 observational clinical studies involving more than 450 patients could show that complications rates are comparable, operating times having become competitive meanwhile, and time to extubation on the intensive care units are decreasing, and time to first oral feedings and leaking rates are rather reduced in compared to open surgery. So this little illustration just showed the approach we had at my former and my current institutions when we started doing this in 2004. We had to convert the first 8 cases due to technical problems, due to anesthesiological related problems. And never since then, when we achieved to complete the procedure, we had to convert, and now this is becoming the gold standard in operating it. One major issue was to deal with our with our pediatric intensivist colleagues, who were arguing that children undergoing minimal invasive thoracoscopic repair for TEF do worse than those open, so we put them, we joined them in order to kind of investigate that, and what we found is that during the operation, obviously the carbon dioxide levels intraoperatively were higher, significantly higher than during open surgery, but postoperatively they were quite equal, and times to extubation and time to get back from the ICU or the PICU to normal wards were shorter, and also recovery altogether was shorter than compared to open surgery. That's what we want to see. This is a newborn with a typical image on the left side of the preoperative setting with a gas bloat in the stomach, and on the right side the completed esophageal continuity with the NG tube in and a small chest tube. This is the same patient, clockwise clamping the fistula right before we divided, we dissected, then mobilizing the upper pouch, then starting the anastomosis, putting an NG tube in to kind of perform the continuity during the healing process. And then this is the right lower picture showing the final aspect of the operation. What I would like to go through is kind of some operational steps. In German history, the division or the dissecting of the azygos vein was almost traditional. However, I know that most of the surgeons I know don't do it anymore. They kind of trying to preserve the azygos vein during the procedure. This is just to illustrate that if you divide it, the landmark to find the fistula is very easy, and in this case we used a sealing device to do that. So then the first step is to isolate the fistula. Here you can nicely see the vagal nerve, which is going to be preserved. The dissection of the fistula is mandatory, and it has to be watertight, airtight, and to kind of provide tightness after the operation in order to avoid any recurrence of the fistula or any air leakage to the fistula. So what we did in the beginning and still kept on doing is to do stitch ligation of the fistula. The only case we had a recurrence was when we used a clip. However, clips and any other dissecting techniques are allowed as long as they can provide the same results. And then the fistula is going to be resected. We don't do this completely in order not to lose the lower part of the esophagus prior to doing the first stitch of the anastomosis. So there are kind of tips, tricks, and pitfalls in dissecting the tracheoesophageal fistula. We always first clamp it to confirm the right structure, and I can confirm that I have been clamping the trachea when I was getting the wrong structure into my forceps. The preservation of the vagal nerve should be achieved. You should keep some little distance to the trachea while ligating it in order not to kind of narrowing the trachea, and when dissecting, do not cut completely. In doubt, consider bronchoscopy at any time of the operation, and we try to place the first anastomotic suture prior to complete dissection of the fistula. A very useful tool in kind of identifying the TEF is using a Fogarty catheter, which can be put in by the anesthesiologist, and which helps you a lot in quickly identifying the fistula. This was a very small infant with 31 weeks of gestational age, and so it also had a lobus veni azygos, which you can see in the right in the picture, which was kind of nice to see. And because the fistula was quite large, we wanted to quickly identify it, and so a Fogarty was put in during bronchoscopy prior to the operational procedure, and then we could easily identify it, preserve the vagal nerve, and identify the fistula and then dissect it. Again, this is using the use of a Fogarty catheter in another patient, which you can nicely identify when it will be drawn back by the anesthesiologist in a second. And then now it's gone, and we can clamp the fistula to confirm that it's the right structure and then proceed with the operation. If you are sure that the fistula is at the right place and you can easily identify it, then the use of the Fogarty catheter might be avoided. Here you can easily identify the fistula, which is then again clamped to confirm the right structure and then going to be dissected. In any doubt, always consider bronchoscopy in order to confirm the position of the fistula, and which will help you to save time and nerves and resources during the operation. And right here you can see right above the tracheal bifurcation, you can easily identify the fistula at the 7 o'clock position. Again, I prefer to do stitch ligation of the fistula. I have never encountered any leaks or any recurrences of the tracheoesophageal fistula, except for one case when we used a clip. This is the most safest method to provide safe and watertight closure of the fistula, to my opinion, but obviously many other can prove the same results while using clips or just ligating techniques. So the second step would then be the mobilization of the upper pouch. Here are again some tips, tricks, and pitfalls. So we ask the anesthetist to push still when the pouch is closed, to push downwards the NG tube in order to provide better identification and better exposition of the closed pouch. If there is a lot of distance, then you might open the upper pouch, put the NG tube through, place a suture to connect the distal esophagus to the NG tube, and let the anesthetist pull it up to help it approximate the lower part of the esophagus to the upper pouch. And always take care when dissecting the upper pouch from the membranous portion of the trachea in order to avoid any predisposition for tracheomalacia. We used to use the electrocautery, the hook, with very low energy and very careful and subtle dissecting of the tissue to mobilize the upper pouch. And we all know we have to mobilize the upper pouch as far as we have, or in order to have a tension-free anastomosis. But on the other hand, we don't want to skeletize it. We don't want to kind of cut it off the vascular supply, and also we don't want to weaken the membranous portion of the trachea. And then I still tend to put the first suture through the pouch, full thickness suture, while the pouch is still closed. And what you can see here is the anesthesiologist pushing down the NG tube, then through the incised lower part of the esophagus, the fistula, we will put the first suture again as a full thickness suture, then put this knotting it together, and then open the upper pouch and complete the anastomosis. When the first sutures are done on the back wall, then we put the NG tube in. Should be go down nice and easy. And then we complete the anastomosis with single interrupted sutures, and that's the final aspect of the completed anastomosis. This is the final aspect with the lobus venae azygos. Just because it's not too common, I wanted to demonstrate it, and that's the case where you for sure don't dissect the azygos vein. So we leave the NG tube in for 10 days, and then always the surgeon himself pulls it back while the radiologist is providing us with a contrast study, and to prove tightness and a patent anastomosis prior to let the children drink at lipidem. And that's also true for the case where in this very small infant. Results and cosmesis are obviously superior, and Steve Rottenberg did a great deal of always describing the advantages of thoracoscopy in comparison to open thoracotomy in order to provide comorbidities associated with thoracotomy. It is true that long gap atresias are a totally different thing. We approached this baby with a long gap atresia and a distance of 6 centimeters after having been waiting for 8 weeks. And we found a nice upper pouch going down to the vena azygos, but there was no lower pouch, so we opened the diaphragm and then could identify a lower pouch just above the size of 1 centimeter, and we kind of achieved appreciation of 1.5 centimeters in order to approximate the 2 pouches, but there was nothing more to do at that time, so we put a stay suture in and just let the child grow for another 6 weeks. That's the situation after the operation or during the operation at 8 weeks. Then we performed a new contrast study and could prove the distance now being of approximately of 2.5 centimeters. We went back in and did a laparoscopy first, kind of mobilizing the hiatus and the intra-abdominal esophagus, then went back in to thoracoscopy, found the stay suture, mobilized the 2 pouches, and could pretty nicely achieve a primary anastomosis of the esophagus. Obviously, the contrast study was not as nice as in the conventional cases with the tracheoesophageal fistulas, but now 2 years after the operation, the child is on full enteral feeds and does not require any dilatations. Steve Rottenberg has described his series of pure thoracoscopic approach to long gap atresias, and obviously there's no question that he himself meant that they have been simply been lucky in kind of completing all those procedures. But I agree with his opinion not to go for gastric pull-up or any other esophageal replacement procedures until we proved that thoracoscopy could not achieve the result. So this is again this child who was then scoped for dilatation 4 weeks post-operatively, and the right picture is showing you the picture right after the pneumatic dilatation. We have done a couple cases with these techniques with pretty satisfying results, but long gap atresia is a long and winding road. Just to lose some words of consecutive thoracoscopy for children with esophageal atresia who might have tracheomalacia. There have been several reports of dealing with that, also from David Fandesi. This is how we did it in some cases. Open the pericardium and then put 3 consecutive sutures through the aortic arch. After identifying the aortic arch within the open pericardium, those sutures then have to be brought up back to the sternum, which is a kind of a challenge for the surgeon, at least to myself, because it's not the most common procedure to stitch the aorta thoracoscopically. Then after bringing back the needle through the sternum to outside, the sternum get then compressed, and the surgeon is then tying the knot exteriorly. This is the result in this case, where the trachea was pretty narrowed, even with high levels of PEEP of 8 millimeter mercury preoperatively, and then postoperatively it was quite nice open with 4 millimeters of PEEP. So sequential thoracoscopic surgery is also safe and effective, and to us it's pretty encouraging to do this consecutive procedures as well, minimal invasively. So going back to history, time for personal learning curves is not acceptable anymore, since there have been 18 years of thoracoscopic surgery for TEF and esophageal atresia repair. And so we have to face a shift of our paradigm. It's not see one, do one, teach one anymore, but it's see one, practice on a simulator, and then do one anymore, and then do one yourself. And simulation using 3D printing models have been or have been even proven to be successful in this highly demanding procedure, to trying to simulate it in safe environments. Those are courtesy of Kathy Barsnitz from Chicago, who has been doing a great deal in developing those models, up to have simplified rubber models where you can easily simulate this operation step by step. If you put this into a simulating device, such a pediatric thoracic cavity, and then to kind of thrill it a little bit more, to do this with animal tissue, the completion of the simulator using animal tissue, which has to be modified surgically to replicate a TEF, can be very useful before you actually go into animal models like a rabbit, where you can easily perform esophageal anastomosis in a live setting. Why all this? Because those baby, they expect us to do it right the first time, and not to do any experimental surgical procedures. So thank you very much. There will be a nice opportunity to learn more about that on the IPEG meeting in London in the upcoming July. And with this, greetings from Lucerne to beautiful Naples. Thank you.
Thank you, Philip, for this nice presentation. Are there any questions?
There are two questions for Michel Schmitz from Switzerland. In case of reconstruction with gastric tube, which is the percentage of cancer or dysplasia? I don't know. The percentage of cancer or dysplasia.
In case of what displacement? Yes. Replacement? Gastric pull-up?
Yes, gastric tube with pull-up.
I have no idea, and probably it's very hypothetical to talk about the risk of cancer. We know there is a significant risk of cancer for patients who have been undergoing gastric pull-ups, but I couldn't tell you the percentage. And is there any alternative to that? I don't think so. So gastric pull-up has been proven to be at least one reasonable alternative in order to replace the esophagus, and there's no alternative in terms of to do nothing and to avoid any cancer.
Here, another question. Agatha Brown from United States. Which are the most common functional complications after surgery?
After minimal invasive surgery, or
after? I think so.
I do personally think that the classical tracheoesophageal fistula combined with esophageal atresia is very safe and very encouraging to be done or to be corrected with thoracoscopic surgery. So we didn't see any complications in our patients, and at least the last 20 to 25 cases which we have been doing thoracoscopically did not require any dilatation or any endoscopic treatment after the surgical procedure for a follow-up of 5 to 10 to 12 years. But there is obviously a big difference to the long gap atresias, where you will encounter a reasonable number of complications, such as strictures, such as leakages, such as malfunction of the nut of the dysmotility of the esophagus, if there is one. And that's have to be distinguished from classical esophageal atresia.
We have time for another question. Rodrigo Pereira from Brazil. Very nice lecture. Do you use selective intubation?
No, not in babies at that age. It's very hard to achieve, and we don't found it necessary, as you are inflating minimal CO2 pressure of 2 to 4 or maybe up to 5 millimeter mercury. The children will get adapted to that, and you will have enough working space, and the anesthesiologist will have enough oxygenation during the operation, and also hypercarbia will stay within reasonable limits. That's what we learned together with our pediatric anesthesiologist in the last 15 years.
There is another question, Marcela Souza, São Paulo. In which case focal repairs are requested instead of primary anastomosis, for your experience? Interesting.
It's a tough question because I don't like focal at all. We did, in a couple cases, we did those stay sutures, but we stayed intracorporally with them. So we put the two stumps together, or the two pouches together, whatever you will call them, and then went back after weeks to do the completion of the procedure. I have never performed a focal procedure myself. I just know from many other surgeons their experiences which have been very different. But I also know about terrible clinical courses which I don't want to see in my patients. So I do not recommend focal technique. And I to be honest, I join the same meaning or opinion with Steve Rottenberg, who has the same opinion about that procedure.
And I make a question, if I have time, and the comments. Usually, if you found a long gap atresia for a type C, normal, but you find the gap is too long, do you prefer to make internal traction, or do you prefer to do direct anastomosis under tension? Because in my experience, I prefer to do an anastomosis under tension, is it possible? And because I agree with you, Fokker technique, in this technique, has the same complication for leakage, and so I prefer to do it in first line anastomosis, tolerating also a little leakage in a postoperative. I don't know what your experience.
It's an ongoing discussion. I mean, there's still the discussion whether the esophagus will grow by completely itself without any tension or without any pushing of the esophageal structures, or a certain tension applied through, for example, the Fokker technique will help to approximate the esophageal pouches together. What we do, if we know that it's a long gap atresia, then we wait until we can kind of assess the distance to be lower than, for example, 4 centimeters, then we would go in for thoracoscopy. If it's more than that, then we wait longer. And I would always, as I said, and then as I cited Steve Rottenberg, I would always try to scope and do it thoracoscopically before considering any other techniques. And then, of course, try to achieve a primary anastomosis, which we did in one case where we could achieve a primary anastomosis in the very first attempt, but that can't be guaranteed.
Two similar questions, one from Egypt and one from Italy, from Lucia, about post-op ventilation. Is different from open, and how long do you use it to use?
So, to be honest, I was very lucky to have a pediatric anesthesiologist in my hospital who just retired a month ago. That was Martin Ure, and all our patients, the last 10 cases, were extubated in the OR and did not require any further ventilation. In one case, that was not the right decision because that child was not doing very well. All other cases did well. They go to the PICU because for monitoring reasons or for monitoring purposes, but they don't require any mechanical ventilation. They were spontaneously breathing right after the operation was completed. And that's a different, I think that's a significant difference to any open thoracotomy procedures where children will for sure require a prolonged ventilation.
Then more question from Fernando Montes Tapia. Which is the limit for permissive hypercarbia? I don't know, it's probably a question for anesthesiologists.
I can just push this question away in the way that it's not just the surgeon who is doing it. It's also a challenge for the anesthesiologist, and it really depends from the experience of the anesthesiologist. So again, with me being lucky, having a very experienced and very serious pediatric anesthesiologist, he always kept me in safe ranges with a hypercarbia below 70, 80. And that never brought me into any kind of problem region. But again, this is highly dependent from your anesthesiological service.
Okay. From Egypt, how do you deal with minor or major leaks if occur? Do you wait or come back again?
There's no way of surgical repair leakage after the operation. I do think that we all agree on that. So if there's any leakage right after the operation or 10 days after the operation, you have to wait. And you have to kind of stay conservative. I have never encountered any leakage after TEF repairs. Maybe I just got lucky, but I have never seen this problem.
Just a question for me. Have you any case of dextrocardia or situs inversus, in which, in this case, which side do you decide? Always on the right, or?
When I was in training, we learned that in case of dextrocardia or right descending aortic arch, we should go to the other side. I know from personal reports that people still stayed on the right side for operating or for correcting esophageal atresia, but to be honest, I have never encountered that. So I don't have any personal experience with that. David, maybe.
David, always from the right?
We've had a few occasions that we had a dextrocardia and we just approached it from the right. It was only one patient which had a complex cardiac malformation as well, and he was surviving on his pending duct, and there we didn't want to take a risk, so that one we approached from the left side. But normally by doing thoracoscopy you can even approach it from the right side to the left side if you need to. You can go around the aortic arch without any problem. So maybe I can take the opportunity to give a caution about surgery in general in neonates, because they get an arterial line, they get an intravenous line, we monitor their Oxygenation, either intra-arterial or by peripheral means, but that only gives you an impression on the level of the body itself and not on the brains. And we all know that neonates are excessively vulnerable with their brain still developing. And contrary to older children and adults who have a sort of compensatory mean to compensate for hypoxia, that they get a preferential flow toward the brain, neonates, in particular prematures, are not able to do that. So as soon as your oxygenation goes down, the oxygenation to the brain goes down. And that's why it is important, if possible, to monitor the brain oxygenation by means of near-infrared spectrometry that you can do nowadays. And I think this is a very important means to make sure that the levels of brain oxygenation remain within acceptable levels. Because it's known from the literature that if you have hypoxia in neonates to the brain, you may have developmental disturbances later on. And in our department, the neonatology department, together with us, have extensively studied these patients, and in a number of these patients on MRIs you could see really devastating anomalies postoperatively. And that's why I started saying that it is in all neonates that you operate. In particular, the patients with gastroschisis are extremely vulnerable to postoperative damage after surgery. So it's not only by minimal invasive surgery, but all surgery in neonates, there needs to be attention for the brain oxygenation.
Only comment from the clips, because I'm exactly the opposite experience. Only in 3 cases in which I ligated with the stitch, I have a little leakage. And so using the clip, 1 centimeter clips, a couple of 1 centimeter clips, I never had a problem. But it's debatable, but it is important to debate it. It's very fast, because the first line is to close the fistula. The anesthesiologist is very happy when you close the fistula, and then you can do everything with more time, I think.
Fabio, I agree completely. So it's faster, it's quicker in order to achieve complete closure of the fistula, and it would be just stupid and apodictic to say this method is the only one. It's always depending from your personal experience. So no further comment.